Thank you very much, Donna and Noel, for the invitation to come here. It's terrific. Now, my original brief was echo in the pre-op clinic, which really is not going to be TOE, is it? So this is a bit of a first diversion. But really, I think we have to move beyond pre-op clinic and think about perioperative environments, and Scott was alluding to this before, where transthoracic echo rather than TOE will become the mainstay. And for many people, this is a bit of a new idea. And let me just remind you of this quote from Victor Hugo, that an invasion of armies can be resisted, but not an idea whose time has come. And I firmly believe that time has come for us. These are my disclosures. And I don't wish to blind you with science in this talk. I simply want to open your eyes to what's possible. And because they're all cardiac guys, almost all of you will be experts in echo, I'm probably preaching to the converted. So this could be an easy talk for me. With one exception, almost all of you will be doing transesophageal echo. And can I just have a hands up who actually does transthoracic? So maybe a quarter to a third. So, of course, TOE is mandatory for our cardiac surgery environment, but once you step outside of the operating room, actually, it's the wrong technology, and transthoracic is going to be far much more useful to you. So let's have a look at why we need to have TE in our everyday practice. Because a lot of my colleagues will say, it ain't broke, Colin, we do a pretty good job, don't fix it, you know. So the first question we have to ask is, how good is our clinical examination? Now, by illusion, I'm showing you it's about 50%, isn't it? You might as well toss a coin when you have patients who are at risk of heart disease and you're trying to work out what's wrong with them. And we actually looked at this in a study in the pre-op clinic where we took 100 patients who were either age 65 or over, all had symptoms or signs suggestive of cardiac disease. And a very complex slide, but just look at the red line. Change in diagnosis and management around 50%. If I break this down, of 100 subjects, 20 had basically no symptoms at all. They just were older. And guess what? 2 of them, or 10%, still had significant new findings. And paradoxically, those who you think had cardiac disease, the change in your diagnosis is often more to say, well, actually, they're okay. So you don't have to worry as much, versus those who you confirm significant findings. And we repeated the study in emergency surgery. That's non-cardiac emergency surgery. Again, 100 patients. 24% were just older. But interestingly, emergency patients, a much higher proportion, actually have significant disease. And similarly, in those who you suspect significant disease, a much higher proportion do have it. And we found that the change in diagnosis and management, again, was around 50%. This is people being assessed predominantly by senior registrars or consultants. When we looked at diagnostic accuracy, agreement for hemodynamic state assessment between the clinician and echo was only 39%. Okay, and of 27 people who had moderate to severe valve lesions, 10 of those were missed by clinical examination. And in fact, we've known this for many years. There were studies about 20 years ago where medical students with limited training having, by today's standards, primitive handheld ultrasounds had better accuracy than a cardiologist with a stethoscope. So this isn't new, it just reinforces in our proportion. And I actually was presented a talk like this at the Chinese Society of Echo last year, and their president followed my talk with a very similar talk, and I borrow a quote from him because it's fantastic. He said that the next generation of doctors will be horrified that in 2014, that's when we gave the talk, that we used a 200-year-old diagnostic tool, the stethoscope. And yes, it's the 200th anniversary this year of the stethoscope. That is only 50% accurate when we had ultrasound available. It's not like ultrasound's not here. We've got it. It's just that we're not using it. So I think it's time we cut the stethoscope and actually replace it with a more modern version. Okay, why should we use transthoracic in perioperative medicine? Essentially, you're going to use it to improve your diagnostic accuracy. But more important than that, you're going to use it by the bedside in real time to answer your clinical questions. So echo and clinical ultrasound in general is not replacing clinical examination, it is complementing it and giving you a higher degree of diagnostic accuracy. And I actually think we've got to get away from calling it echo. I think we've just got to simplify this concept. You're going to have either ultrasound-assisted examination or ultrasound-guided procedures. And that gets us away from, I'm going to do a lung scan today versus a transthoracic echo. You're going to pick a probe up and look at the lungs, or you're going to look at the heart, or you can look at somewhere else. And essentially what we're doing here is ultrasound-assisted assessment of the heart. I think once you get that in your mindset, we stop fussing so much about trying to categorise different ultrasound uses. Now, we all like a case, don't we? We've got to wake ourselves up a bit. So let's look at this one. Here's a 75-year-old female for a VATS pleurodesis. Okay? She looks a bit frail, doesn't she? But she's walking, able to do her own shopping. The trouble is, got one of these guys, surgeon, who wants to operate. Okay? And that's when it all gets messed up, doesn't it? Okay? Now, when you clinically assessed her, she's got no known cardiac conditions, but she doesn't exercise. Okay? She has bad osteoarthritis of her hips. She doesn't get short of breath, but guess what? She doesn't exercise. And she also has diabetes, hypertension, a smoker. In short, she's basically a slug. Okay? But in the great way of Nike, I decide she's fine, just do it. Whack off to her sleep with a general anaesthetic. Guess what happens? Severe hypotension, arrest, can't get it back. Game over. Okay? And I'm left like this poor puppy dog in the kennels wondering why. I just can't understand what went wrong. So tell me what I missed. That's a short axis view. I'll show you the long axis view. Oh, it's not playing. Let me just see if I can play that. Sorry. Just imagine this is playing. Okay, I want you to look at here. Let's go back to that short axis view. What have we got?
Slow rising pulse.
Very slow rising pulse. All right, so clearly we've got no aortic stenosis, haven't we? I missed that. Now, I'm sorry this isn't playing, but you'll also notice a very large left atrium, relatively small or normal sized ventricle. And that tells you that these big atria that don't empty is because they're high pressure. This lady's got diastolic failure as well. Now, do we have any orthopods? Would anyone in this theatre like to be an orthopaedic surgeon? Are you married to one? Because all orthopaedic surgeons get this. Do you believe that 100% of orthopaedic surgeons make the right diagnosis? Hands up. Thank you. Because the pattern recognition is that it's a heart bone. See the fracture line? Just here? Okay. The only trouble is our orthopaedic colleagues have a slightly different way of treating this to our surgeons. Those leaflets will never, ever move again. Okay, so when we think about the perioperative use of ultrasound, almost always when things go bad, our warning sign is hypotension. That's our trigger, okay? But we've got to think of how ultrasound-assisted assessment of the heart can pick the big-ticket items. We can identify hypovolemia because it's direct vision, okay? Our brain has to tell us if this is relative or absolute, whether we've lost blood or we've distributed, okay? We can differentiate the different types of heart failure. Isolated left heart failure, right heart failure, left and right heart failure, diastolic heart failure, systolic and diastolic heart failure. Because each of those conditions you're going to treat slightly differently. We'll pick the major valve failures, whether it's stenosis or regurgitation. It's quite easy to pick vasodilation. Okay? And of course we will also look for some of those other things core to our business, such as tamponade, whether it's pericardial, large pleural effusions, and so forth. And there's a lot more to that. There's a lot more, but these are big ticket items. What we're doing with our basic transthoracic echo is really just going from about a 50% accuracy to a 90% plus accuracy. You shouldn't expect 100% accuracy, okay, because we'll all miss things, and a lot of patients don't get great views, but you get enough to help guide you to the next step. Essentially, you're separating good, bad and ugly. And this is an example of good, okay? Well-filled left ventricle, contracting nicely. Notice the left atrium, aorta, RV is all the same size, and that's Royse's rule of thirds. It's all in proportion. This is a happy left atrium, likely of normal diastolic function. We put the colour flow Doppler on and we're not seeing any aortic regurg stenosis, any colour acceleration anywhere. And in short axis, of course, the dancing donut is circular. We have a croissant-shaped right ventricle. It's all in proportion. In 1 microsecond, your eyes can differentiate this one, because clearly we've got a dilated left heart. That's contracting poorly. But look, the aortic valve's normal. That's opening beautifully. And a smallish left atrium. Empties nicely. And in my pattern recognition, this patient probably doesn't have a lot of diastolic failure, and this might be something you see in your young cardiomyopathies. You, of course, have a dancing donut that's huge and rocking rather than contracting. This is bad. This is also bad. We can all see these very thickened and abnormal-looking mitral leaflets and a dilated heart and a huge left atrium. And if I put colour flow Doppler on that, it confirms the obvious from the anterior leaf prolapse that we've got very significant mitral regurgitation. If you see this in your pre-op clinic, this is the downright ugly. Okay? Why? Because firstly, we've got terrible LV function. Hey, we've also got the heart bone, a big left atrium, and look, the right side looks like a soccer ball. It's bigger than the aorta. I'm thinking this patient's as well got some right ventricular failure. So when I flip it into the short axis view, we see this monster right heart physically squashing the left. And we see the D shape rather than O shape of the left ventricle. And if we happen to do a long axis apical 4-chamber view, the RV is actually bigger, which of course it shouldn't be. There's a bit of a pericardial effusion happening as well. And surprise, surprise, severe tricuspid regurgitation. Now, if I see that in the pre-op clinic, what do you think I'm going to do with this patient? Well, actually, what I do is I say fit for anaesthesia when I'm away somewhere else, like Manchester. So I'm out of the country when it happens, right? Because that's a disaster case. Horrible. This is what hypervolemia can look like. It's a small chamber cavity that's contracting normally. Now, I can't tell you that's in blood loss or vasodilation, redistribution. Your brain has to put that in. Here's another example of hypervolemic. Just small cavities. Whereas this is vasodilation. Okay, now, what you've got to say is actually freeze your mind to end diastole. It's well filled, but it almost completely ejects. And this is what happens. As you lower your SVR, you eject more, okay? Add a blood pressure of 80 to that, that's a diagnosis of vasodilation. Takes about 2 seconds to work that out. Let's not stop at the heart. Now, I'm not going to talk about this because I know there are other sessions on this in this program. But obviously lung ultrasound, so easy. There are 6 abnormal patterns, guys, and it's no problem getting images. Okay, DVT assessment, dead easy. Abdominal assessment, that's an area we're really going to expand. I had a great talk with Andre Deno from Canada about pulsing the portal vein as a sign of hypervolemia. Once you kind of know how to do it, it's not a big ad, but it can really improve your diagnostic accuracy. Airways, perk trachees, find the midline. Gastric emptying, single view, empty or full. Bladder size, bleeding, have you bleeding into the chest, etc., etc., etc. Just think of it as ultrasound-assisted assessment. And by the way, how good are we at blind insertion of catheters? Okay, it's a long time since I've done that. And so our ultrasound-guided procedures will be not vascular, ultrasound-guided regional, which we've been doing for years. How about intercostal insertion? You don't have to real-time guide it, but you can map out the effusion. You can map out the kidney, the spleen, or the liver so you don't spike it with your chest tube. tracheostomies. Find the midline, avoid the thyroid that's coming across, and pericardial drainage. Last time I saw one of these done was by a cardiologist in the cath lab under fluoroscopy, and it went something like this. And I was horrified because we could do it so much better with an ultrasound-guided technique. So it is a transition. It's a new idea, new concept, but once you get more and more familiar, it almost becomes integral to your decision-making, your procedural accuracy. It actually is a little bit more subtle too. It fundamentally changes our behaviour. Okay? We stop becoming reactive therapists and we start becoming proactive therapists. Let me explain what I mean by this. This is now, okay, typical. I thought Mrs. Bloggs was fine, put her to sleep. Guess what? She gets hypotension. So I react to that by giving fluids and vasopressors, and then she gets more hypertension, and then I react again by giving more fluids, and then maybe I think why, and I scramble for an echo machine if I have one available, or a colleague who can do it. Imagine if I'd done that echo on her beforehand and found aortic stenosis and diastolic heart failure. I'm going to plan differently. Yeah, I'm going to up my monitoring. I actually personally would start a vasopressor and an inotrope 5 to 10 minutes before induction. I want to see the pressures go up before I reverse that pressure up with my anaesthetic, where we will dilate and we will lose contractility. And guess what? I don't get hypotension. I monitor appropriately and I plan appropriately for her because she needs this therapy to continue until the bleeding stopped, until the inflammatory response has started to wear off. That's the proactive therapist. And I'm amazed when I talk to colleagues about this, and they're sort of thinking I'm a guy with two heads on and a bit stupid. I say to them, well, what would you do with a difficult airway? Do you just give a big dose of pancuronium and some propofol, and you haven't even got the difficult airway trolley in your room? They say, of course not. We have all these steps lined up and we have everything ready and we're prepared. So what we're doing by adding our diagnostic information is treating cardiovascular like we do a difficult airway. Diagnose it, predict it, and prevent problems. It's not difficult. Better diagnosis makes us smarter doctors. And guess what? Smarter doctors treat patients better. This is the million-dollar question though, isn't it? We can do all this, but does it actually make a difference to the patients? Let's have a few caveats. Ultrasound is a diagnosis, not an intervention. Okay? You can lead a horse to water, but you can't make them drink it. I could show all of you the same pictures we saw here. Some of you may choose to completely ignore that and do your usual thing. Okay? So by diagnosing it doesn't mean we will get the right intervention. The other problem is that you can't herd cats. And anaesthetists and surgeons are cats. Okay? We all have our set ways and ideas, and it's very difficult to get you all on the same page. So the same diagnosis might produce 10 different interventions. 9 of them might be really good and 1 might be lousy. And that, of course, can cloud any study that looks at intervention. And surprisingly, there is yet no RCT available on physician-performed echo on mortality or morbidity. A few proposed, but not yet funded. So the closest proof of concept, and it's all it is, it's proof of concept, is a study that we did in Melbourne on people who had fractured neck of femur surgery. Now, we took the patients from the 2 studies I've shown you previously, the emergency surgery and pre-admission clinic, and people who had hip fractures who had echo. And then we took the same cohort, year cohort, got all the patients who didn't have echo and randomised them and got a matched cohort number of patients. Okay? And in fact, they were very well matched groups. There were no differences between these 2 groups. But at 12 months, the mortality was strikingly different. It was 10.9% in those patients receiving echo and 28.8% in those who did not. Right, don't walk away please and say we've got to do echo and all hip surgery, because this is retrospective data and it's proof of concept. But it does impress the need that we actually do have to get off and do some studies where this whole concept of the echo improving diagnosis changes our behaviour to produce better outcomes. It's quite a complex thing to do. But if we do, then I think we'll be closer to the full human evolution, where that's probably needs to be replaced with a little handheld device now, but we're getting closer, aren't we? And what's fascinating, of course, this is actually even the cardiologists in America have come to the table and acknowledged cardiac focused ultrasound, which is their version of basic transthoracic echo. That they're actually saying it's a good thing. They do also say, mind you, you probably shouldn't bill for it unless you're trained and expert. But it is on the table now that people are saying, societies are saying, that this is a good thing to do. So I'll conclude by saying, I want you all to stop thinking about echo and stop thinking about lung ultrasound and just think about ultrasound-assisted examination and ultrasound-guided procedures. Although in perioperative medicine, the transthoracic most commonly will be used basically for answering your clinical questions. I heard a murmur, or the patient's not well, doesn't exercise, so I can't assess their exercise tolerance. Let's look at that ventricle, let's look at that valve, rule out the aortic stenosis. Ventricle looks good, I'm happy. Or you find something and you can plan appropriately. So for those still not convinced, let me remind you of my second favourite quote on this area. This is written about 300 years ago. A new idea is first condemned as ridiculous and then dismissed as trivial until it becomes what everyone knows. In cardiac surgery, TOE is what everyone knows. It's not too far from now. Perioperative ultrasound will be what everyone knows. Thank you for your attention.